Good morning and welcome to our monthly webcast. I am Samir Mehta, your moderator, and this is session number 120. Today it is 10 years of doing the monthly webcast and it is absolutely unbelievable. This morning it crossed my mind that if God made me live till 80, then 12.5% of my entire life would have transpired during the time we have been doing this webcast. This observation alone makes the webcast one of the most important events in my professional life. Here are some facts for you. Since day one, it has been the same team. Since day one, we have not changed the format even once. And since day one, there has never ever been any conflict of interest at ccclivecases.org. In fact, I have never uttered the name of any product in 10 years, and I have no intention of doing so today or in the future. There has never ever been a conflict of interest in our webcast, and it is going to be the same mandate we will follow in the future. As I reflect further on the last 10 years of doing these cases, I believe we have made three invaluable contributions to interventional cardiology. Number one, I think we have educated the world about the appropriateness criteria, and I am sure that you would have noticed how diligently Dr. Sharma reviews the criteria before every case and every procedure that we do. Number two, I also firmly believe that our webcast is possibly the best place to learn complex coronary interventions. My Lumen Foundation has set up heart attack programs in more than 30 countries, and the observation I make is founded on the feedback I obtain from these numerous countries. And lastly, as number three, I believe that we have pioneered numerous apps that are being used globally for a step-by-step learning of complex coronary interventions, and for this I think the credit alone goes to Dr. Kinney. On the auspicious occasion of completing 10 years of our webcast, there are many people to thank. Foremost, my family for the sacrifices they made often to enable me to come to New York each month. Next, of course, my gratitude goes to Dr. Sharma and to Dr. Kinney, simply the best angioplaster in the world. There is also no place like Mount Sinai, possibly the best on the planet, where interventions can be performed, in particular the complex procedures. I also want to thank Guy Puglisi and his team of engineers and camera crew. Here is another mind-blowing statistic. This is the same team that has recorded all 120 sessions. Lastly, to Kimberly Costow, without whose logistical support none of this is ever possible. It has been an absolute privilege bringing these cases to you. Over the last 10 years, I have encountered hundreds of cardiologists, all perfect strangers, who have often stopped me and complimented about this webcast. Your encouragement is precious, and I will never take it for granted. My simple response to all this encouragement is that we'll continue to do the same job with absolute sincerity. On the occasion of our completing 10 years, there are three eminent guests which we have invited today, standing in the cardiac catheterization laboratory with Dr. Kinney and Dr. Sharma are going to be Dr. Habib Samadi and Dr. Ron Waxman, and joining me in the moderator room on the left, I'm sure you've been seeing him right through as I've been speaking, is Dr. Michael Gibson. I'll start by introducing Mike briefly. He's absolutely no stranger to interventional cardiology. I actually call Mike a combination of all in one person rolled together: Eugene Braunwald, Mike Wallace, and Van Gogh. How about that?
Wow.
Those are your remarkable talents as I've known you. Dr. Gibson comes to us from Boston. He's a professor of medicine at Harvard Medical School, and he's also pioneered areas of involving physicians and cardiologists globally in social networking environment, which I'll be talking to you. Mike, welcome to Mount Sinai. In the cardiac catheterization laboratory, we have Dr. Ron Waxman. Ron is a professor of medicine at Georgetown University. Yeah, I get confused between Georgetown and MedStar, and of course Ron is the course director at the amazing CRT course, which I think is possibly in the 23rd or 24th year. We'll confirm that. And also joining us from Emory University is Dr. Habib Samadi, who's the Chief of Interventional Cardiology and the Director of Cardiac Catheterization Laboratory, and more importantly also the Deputy Editor of JACC Interventions. So with these three eminent cardiologists, every aspect of academic and interventional cardiology is covered. We'll lean on their combined wisdom with the case. And with all these introductions and our gratitude for all the viewers who have been following us for the last 10 years, it's my pleasure to take you to the cardiac catheterization laboratory. Samin, Anu, good morning.
Good morning.
Good morning, and thanks for the great startup and brief history of our 120th episode today. And I'm so privileged to have three, our guest moderators, I would call them, because we had two but at one point, and with like a 100th celebration when Sunil Rao and Dr. Mauli Turner were here. And now we are three. So clearly, that exemplify the, I would say, the success or celebration we are having, or feel pride in taking this whole concept to our case number 120. And as you said, right from the first to 120th, our theme remained the same. And theme basically is making it appropriate and show the technical aspects. And I'm very privileged to have both with the immense knowledge, both theoretical as well as practical, hands-on, with Habib as well as Waxman, and Ran will tell us during the case. And I really thank both of you to be here. And I know that Ran particularly just went home a few days ago from the great interaction on the Thursday, June 13th, with the part of the CCC live case symposium. And of course, welcome back. Anu?
Thank you. Yeah, good morning everybody. I know everybody has thanked the entire team, but I just want to thank the Cath Lab, who has been very supportive. And why we are able to get these patients on time everywhere is because of our team as well as intervention fellows. I have two intervention fellows here. We have Nilesh as well as Deepika behind me. And what Dr. Sharma mentioned, and most people probably who have watched the symposium on 13th, that both, I know we are forefront doing majority of the procedures, but we have our junior faculty, and one of them is Asad Khan, who is right here next to me, trained by myself and Dr. Sharma for both interventional as well as structural. Amazing guy, and now he'll be moving on to another job back to his country, taking all the tips and tricks that we have taught him at Mount Sinai.
Anu, over the last 10 years, I have at least watched 50 of your fellows complete from here, and they are doing some amazing work around the country. Tell us about the case today, a truly complex coronary intervention plan.
Good. Okay, we can get to the slides, so that what we'll do, and as we move along, we'll continue our input from now calcific aid, another aid, the aid which Anu introduced last Thursday, the day of our the CCC symposium, which is the calcific aid, because calcium is always a trouble and has been a part of our discussion many times in the live cases. And actually one of the highest viewed case is the bifurcation calcific lesion, where we did a rotablation of both the branches and put 2 stents. That actually is over 40,000 views on that particular case. So Anu will take us through this calcific aid.
Anu, and before you do that, this is available online today.
It's free, was released last week. Anybody can download it either from the App Store or Google Play, depending on what kind of
This
phone they
makes
carry.
it the fourth app which your team has developed and available?
Fifth one.
Fifth one. Congratulations. Tell us about this one.
Yeah, so essentially I think we all know the focus is calcium. For right now, for interventional cardiologist, I think the focus is, we say it's a nightmare as soon as we see calcium. So bifurcation, calcium and total occlusion. This is I think where everybody has to master if you are going to the next level of intervention. So calcificate only concentrates on calcium now. So if you see here, as soon as you go in, you will choose what kind of your lesion that you want to do, whether it is essentially a simple calcific lesion, non-left main bifurcation lesion, a bifurcation lesion, instant restenosis or undilatable lesion. So everything is covered, and then what you see is degree of calcium. Why degree of calcium? Again, same, mild to moderate is you can do without atherectomy, you can just do atherectomy. If you have to do atherectomy or you are not sure, we always say do intravascular imaging and then make your decision which kind of a technique that you should be using. If it is simple atherectomy, we go through all the various balloon technique that is available, and then atherectomy we have discussed rota, orbital atherectomy, laser, what to be done. And other thing we also mentioned is calcific osteal and non-osteal lesions, how to handle them, and use of osteal flash balloon if at all the need arises in this particular app.
Good.
Excellent, Anu. Here is a question which is coming from a Dr. Rao. I assume this is coming from India. Are all the apps, I think we've already answered it, are all the apps free?
Yes.
They are free.
Okay.
They are educational app,
Yeah.
and Mount Sinai has been very kind to host all of them. They are free to be downloaded at any time, as I mentioned, either from the App Store or Google Play.
And Samin, there is a question for you. Are both the abbreviated and long form sessions available to be viewed?
Yeah, so so far we have 6 or 7 of them, but yes, the idea would be that at least from 17, 18 and now 19, we'll have a 20-minute abbreviated technical aspects in which there is no didactic discussion, although the flow will continue, and your assistant is greatly thankful to make those really 20 minutes, because we always were concerned that can we abbreviate the whole show into the 20 minutes because of various demand. So now we actually have, I think 7 or 8 already, which is already written, abbreviated 20-minute video, and that can be, will extend to, I thought that we just go back to 2017. So 17, 18 and 19 will have this abbreviated version which is available, and it is still, you can still download your slides and question answers and separate. But the key is that just to want to see the technical aspect, so that 20 minutes will be, we expect, because we did the web analysis, Kim did, they found that 21 minute is the reasonable, because we also saw that most of them, the YouTube and so on our page views, the average span of people who hit is 21 minutes. So even the show, the presentation is for 65 minutes or sometimes even 90, but average comes out to be 21 minutes.
Look, I
right?
have
Is that?
Yeah.
Yeah.
absolutely no doubt that the viewership will increase with that. In the meantime, Samin, I can predict that we'll hit a record number of viewers today, because Dr. Gibson here has been tweeting the webcast around the world.
The
Mike,
master,
how
the master
many
tweeter.
tweets have you already sent?
3 or 4. I'm just letting people know that there are the apps at the
Excellent.
App Store, that it's free, and so far there's 5 apps that they can go download and get all the tips and tricks for complex anatomy. I use them. I think they're spectacular. Thanks, Dr. Koenig. This is a great addition.
This is, I have a master interventional cardiologist and an expert in social media. We have much to learn from Dr. Gibson. Samin, tell us about the case and what are your plans?
Good. Now, Anu, you want to just comment on this last slide of the calcific going into the bifurcate?
So what has also we have done is calcified. If we are doing a left main calcific lesion, non-left main lesion, and their bifurcation, we have go through the steps of how to manage the calcium and subsequently how to manage the bifurcation, the various bifurcation techniques. So we have linked from calcificate to bifurcate, or if you don't want to link, we have mentioned about 2-stent technique, single stent technique, the various stent technique, and briefly the steps, because many of the reviews that I got back for the bifurcate, people were that put it in a single page all the steps rather than going from multiple what I would say pages. So they wanted in one page see all the steps. So we have made that modification in calcificate, especially decay crush, mini crush, culotte. All these steps have been described from in calcificate also, saying that okay, this is how you take care of a calcific bifurcation lesion. If your vessel side branch is greater than 2.5 and you are going for dedicated 2-stent technique, so in 2 seconds you will see the steps. How would you do the 2-stent technique, whatever stent technique that you have decided you want to do.
Okay, with that note, let's go to our today's case. These are our supporters. The disclosures, nothing has changed. This is the case number 120, 73-year-old patient who actually started his problem with the extensive PAD. He apparently had one MI in the remote past and initially had PTA a few months ago and has a mild angina which he continued, and then because of the pre-op for vascular surgery after PTA, he has extensive infrapopliteal and infratibial disease. They wanted to do surgery and they did a stress test which was ischemia both anterior and inferior and also severe LV dysfunction, for which patient had a cardiac cath and that revealed 2 vessel disease, although they call 3, but I think it was only 2 vessel. Cath was done outside, and this is the LV function which is about 25%. The actually MPI, we can go to the angiogram. MPI actually showed ejection fraction of 18%, but this is by echo was 25%. I think this is more, it looks like about 25%.
So Samin, although so much has changed, maybe some things haven't changed that much. 10 years ago, first case was the Impella.
Yes.
And so here we are 10 years later.
It's a little different only. The first case was our Impella assisted calcific left main.
Right.
Here is the calcific LAD. Yes. I know.
So this is a totally occluded RCA.
Very big RCA. You'll see it by the collaterals.
EF, we've got it.
Yeah.
So Anu, what are your plans?
Yeah. Let's show that lesion. Yeah.
So this is where I think if you see here, the circ looks okay. This is the native circ.
Yeah.
And this is where we are with the complex LAD.
Massive collaterals to
Yeah.
the circ.
Look at it. Do the RCA. Beautiful.
Right.
Mega. And it's an angulated, little aneurysmal. And I always say that in order to judge the calcium, that is we did part of the MACE trial, that you just go on the cine. See, before the dye comes in, you can see the tram track of the LAD clear cut on the both the walls. So this is a severe calcium and of course significant narrowing, and I'll ask both Ran and Habib to comment on it while we start this process, that how we are going to deal with this particular heavily calcific case with a low ejection fraction. So the patient is on good medical therapy and the patient, what happened is after the initial PTA, they wanted to bring him back and then he developed some thrombus into the other vessels. So they started him on apixaban and the surgery was cancelled. So he did not have a vascular surgery yet and for which he is now here for the complex calcific PCI, which will patient is appropriate. We always go through the appropriateness criteria.
Just I want you to pause here for a moment.
Yep.
Mike, this is how we have started every case by putting in the grid there. And any thoughts on this? You think this is a good way to educate people?
Spectacular to see promoting the appropriate use criteria, and mercifully there's more green on this chart than there is red, but this is very, very important. You don't want people leaving these sessions going out and doing appropriate things. I think it's great to guide them to the appropriate use criteria and show them directly which grid or which box you're talking about here.
Excellent. Samin, please proceed.
Okay. Anu, you want to say what? Yeah. We start.
Maybe I can
Yeah,
make
yeah,
a couple
definitely,
of comments.
definitely.
First of all, congratulations on this celebration. It's really a great achievement. One of the issues are two diagonals that are at the beginning and at the end of the lesion. And I wonder if you consider to protect them while you're doing the PCI at some point, maybe not through the CSI, but maybe after, and get better assessment. Is this is a 1-1-1, especially the upper diagonal, which made the case much more complex than rather deal without bifurcation involvement, because you have two, I would say, significant size diagonals, the second and the third there, that should be considered. So I wonder what's your strategy, Kini, or?
Yeah, I mean, this kind of case after atherectomy, we'll wire before, and definitely wire at least one of them and jail the wire during the intervention.
And one more comment about the PAD. When you put the impella in, you want to assess that you have enough room for the iliacs to get the impella. If not, then I think we can do shockwave right now, because that helps a little bit to facilitate. In this case, I assume it was fine, because we see the impella came in with no problems.
Right.
Excellent, Ron. Good comments. I have further questions for you regarding impella, but we'll wait till I hear what is the plan Dr. Kinney has.
Yeah, that was an excellent, I think, suggestion by Dr. Ron Waxman. We went to caudal view. We have gone as much permittable. You see that we could not see the ostium of the diag in this caudal. I'm just giving a teaching point to the fellows out there that when you have very high diag, the best view to see if there is osteal involvement, or if you are doing bifurcation stenting, caudal, which is 40, sometimes even 60 LAO, 40 caudal, depending on which view, that is the best view to really see the ostium, which we could not see it very well here. And going back to the point, how we are going to handle this, if you see there, calcific long lesion, but what is challenging here is there is that small aneurysmal segment just after the vessel, but not as bad as the aneurysm that we had shown last week. So wiring could be.
That was impressive during live case.
Right.
Yeah.
So
that I believe was one of the best cases for the meeting.
Yes.
Yeah.
So you don't have any concerns to do the CSI past the aneurysm, or you're going to stop just before the aneurysm? Because you have the lesion after the aneurysm.
Yeah, exactly.
So you're going to pass it, you don't have any concerns.
Samin, I'm going to bring in Dr. Samadhi here for a moment. Habib, I have two questions for you, and the first one is based on my reading about your being raised in Sheffield, England. But the questions I have for you, and you can choose whichever you want to answer first. What would be your approach to the calcified lesions, rotablator versus orbital? And then the other question is, you think England will beat India in the World Cup?
Well, let me take the first question
All
first.
right.
Yeah, with respect to the calcified lesion here, I agree, as Dr. Sharma said, that there's pretty intense calcification. So sometimes people advocate doing intravascular imaging in order to decide whether you do debulking. I think in this case, as Dr. Sharma mentioned, the angiogram itself is very impressive with respect to the calcific burden. So I think definite debulking strategy is appropriate here. I don't think even getting good intravascular images up front are likely going to happen. So with respect to rotational atherectomy versus orbital atherectomy, honestly, I think either would be fine as a strategy here. Because the vessel looks pretty large, it looks like it's probably going to be at least a 4-0 vessel. I would probably lean towards orbital atherectomy. And you may want to get to that aneurysmal section and then maybe pull back and sort of do your atherectomy on the way back, if you will. And then once you do that, I think intravascular imaging is really critical.
Clearly, you are a master of interventional cardiology. Now to cricket. What about that more difficult question?
He's amongst all the Indians, so let's see where he's supporting.
Right. I think that I'll probably punt on that one, given the environment here. But I think it's going to be very exciting. I mean, it's good to see. India is obviously always one of the the leaders in cricket, and the English look like they're learning how to bowl fast now
Right.
too.
The only challenge this year has been the English weather, and hopefully the rains will stay away. Ron, would you have also, if this was at MedStar Washington, Impella always?
Yeah, I think this is a very appropriate case for Impella for high-risk PCI. I think it's all justified. It's a very high risk. You have a total occlusion of the right. This is a very complex lesion in the LAD. God forbid something happens, you want to have the Impella in place. It gives you security during the procedure, so I definitely would support the use of Impella here.
Ron, you're also very bullish about shockwave. You think these cases would fit very well for that?
Well, remain to be seen. I mean, we are right now in a disrupt trial for calcified lesions in the coronary arteries. I think this case probably would fit that. It's calcified,
Right.
it's long, and it would be adding another dimensions to treat calcified lesions. Calcified lesions becoming more and more as our population aging. There are a variety of calcified lesions, as was mentioned by Kini and Samin, and I think it's nice to have another tool that considered to be safe. We'll see the efficacy through the trials and also the long-term outcome of that. So we still need to learn, but I think shockwave is a good opportunity to add to the armamentarium of calcium treatment.
Maybe just if I can add to that, I think that there is a lot of excitement around shockwave. Obviously, one of the issues is delivering the equipment, and I see such a tight lesion like this. I think, Ron, what do you think? Do you think you may need a little bit of debulking to even deliver shockwave? It's obviously not FDA approved in the United States for the coronary work at
No,
this
it's only in
point.
the study, but I think pre-dilatation with the tube balloon may facilitate.
Yeah.
In the case it's not, you can use the 125 bear
Yeah.
to facilitate. But again, we need to get some more experience. The overseas experience is so far very optimistic. Also, you should have seen Dr. Kinney was wired very elegantly using a support catheter, the wire. It's not that trivial to cross those aneurysms. Sometimes you have the wire buckled in the aneurysm segment, but she made it seamless. So I should give her the credit for that, with her technique for that.
And these cases will always say, particularly it was a TIMI3 minus flow here, that go with your workhorse wire, and even if it looks like that you may get your Viper wire or Rota, whatever you decide, but better you change, go with your workhorse wire. So same multiple advancement of they call crown, not the burr for the Rota, and 20 to 25 second each time, and slow advancement 1 millimeter per second, and both going forward as well as backward.
Yeah, and the slow is, I think, the
Yeah.
key here
Yeah.
to prevent complication during the orbital atherectomy. So,
And 80,000 RPM.
yeah, the
Samir,
slower the
how
better.
much is the augmentation we are getting from the Impella head?
2.3 liters.
And the blood pressure is stable
Very good.
with a 140 over 77. So we really have a very stable hemodynamics. It really makes the case seamless when you have the Impella in place here.
Both Habib and Ron, what's your respective use of Orbital in your labs at the moment? Stays the rotaplator cases are getting a little less?
Yeah, I would say in our lab, it's a little bit dependent on the operators. I
People
think,
choosing Orbital more for ease of use?
well, yes, I would say so. Yeah, as you know, John Douglas, one of my
Remote.
senior partners, has
Senior.
tried and true and sticking with rotational atherectomy for most of his cases, but most of us have evolved towards orbital. I think in this particular case, the vessel is quite large, and so if you were to take a rotational approach, you'd have to start with a small burr and then perhaps upsize to a 2.0 burr or even a 2.25 burr. So I think to your point, Shamir, the big thing is the simplicity of
Right,
orbital here,
Right.
where the setup's quick and the single pass. The other big advantage, I think, is
Get me the
especially
run-through.
for osteo lesions and so forth, is you can kind of go distal and start burring proximal, so you don't worry as much about perforations going around a bend, although it clearly can happen. And the technique that Dr. Sharma mentioned is critical, going slow at 1 millimeter per second.
Yeah, so what happened at Sinai, we still, just because of it has been the rota, rota gud, which we call. So we actually are at present, our atherectomy volume is about 22%. We do about 340 coronary interventions per month. Total atherectomy volume is 22%, 75% is rota, about 22% is orbital, and 2 to 3% laser.
Wow.
So that is how we
You
are.
want to mention about the rotor glide?
Yeah, I
the
think
wire?
that
I mean
we
the
have to mention
whatever the
that
glide one.
atherectomy are underutilized worldwide, not only in the US. Our lab is not as much as Sinai because, again, we are more diversified maybe in terms of the operators, but I would say that mostly globally the trend is around 5%, we are doubling that. And our use is very similar. The old generation operators still feel more comfortable with atherectomy, rotational atherectomy. The younger generation definitely vote for CSI.
Yeah.
So I think it's a question of a generation gap, but I would say that for most lesions, both of them are fine. If you really have a ring of calcium, I would prefer to go with rotational.
Ron, my own personal take on this is that the majority of the people are actually using neither of the two, and they are just staying with the high pressure balloons or once in a while a cutting balloon.
No, but that is true. Actually, just now, the last, and I follow that very closely to our ACC NCDR. So, ACC NCDR latest report of third quarter, because we don't have full of the 2018 yet. At the third quarter, they just passed 5% mark. Now they are 5.1%. There is no separate distinction which atherectomy it is, but it has gone to 5% plus. In New York State, now the last report we had of the 2018 is about 6.8%, but that is because Sinai representing 22%. So we represent more than
bias.
Yeah, we represent. We do about more than about 10% of the entire state volume.
Wow.
Ron and Habib, both of you are participating in Eclipse.
Yeah, we do, and we are enrolling into that study. It's a long road to finish it, but I do like to make a projection that when Shockwave would be approved,
Down.
the overutilization of any of those devices for calcified lesions will double or triple because of ease of use of Shockwave, and I think people would pay more attention to the variety of tools that are available. I think one of the reasons why people not using that much is the lack of security, and anyone who had some complication think about 3 times whether he wants to pull out those devices from the shelf. So it's a question of feeling more secured when you're doing the procedure.
Let me get some views on the global. Mike, nobody is more attuned to the events happening around the world. What's happening with calcified lesions globally?
We just go to the back.
You get an incredible amount of feedback from all over.
Yeah, no, I think, as Dr. Sharma pointed out, the central tendency is to not use atherectomy. As he pointed out, numbers from 4 to 6% of cases. I just put a poll up, and on our poll, we must have a fairly young audience. 67% of people doing atherectomy are doing orbital instead of directional. So 2 to 1 in our poll.
You were able to get this right now?
Right now.
Samin and Anu, this is, we continue to make progress behind the scenes here. So Dr. Gibson here asked his audience, and we have some poll numbers.
Yeah, so we have a young audience, I guess, 2 to 1 in favor of orbital.
Wow.
And then for stenting, actually 3 to 1 in favor of provisional versus dedicated 2-stent techniques. I said for a typical LED diag. This is not a typical LED diag lesion, so it probably does not apply here.
Because of the length and the
Length and
calcification.
calcification.
Even if you leave the wire, that's it.
Still a lot of
Let's decide about the
still a
stenting.
lot of provisional stenting out there throughout the world.
So let's get focused back on the case. This is a hydrophilic wire.
This
based
is
on the
the-
diagram.
So let's, I think, go back to the technical things, which I think Dr. Ron Waxman just was asking. What is the wire that we are using for side branch access?
The last one.
Right now, what we used is a hydrophilic, which is a fielder wire. You know, it's a polymer jacketed wire, which is very easy to get into side branches.
For the diagonal.
For the diagonal.
Diagonal,
Yeah.
D3 actually.
Got it?
Yeah.
Well, one of the points I wanted to make was that as you,
Understand.
Dr. Keeney was expertly wiring these vessels, you noticed that with the orbital atherectomy, the flow went down a little bit. This is where the Impella, I think, really makes all the difference. Otherwise, with an
38, no?
ejection
Science?
fraction of
38.
15%,
But from where to where?
and getting transiently
D1.
reduced flow, we would have had a hemodynamic issue, but
Little.
seems like hemodynamically we're doing really well, and I noticed Dr. Sharma gave a little bit of verapamil distally
Yep.
to help with
Nipride.
the
There
or
may be
is it
some spasm
nipride?
there downstream. So
Yeah, Habib, both you and Ron had pointed to the possibility, and I'm glad we have the Impella there. Habib, also the feedback which Dr. Gibson just provided, share it with Tanveer Rob. Tell him that people
On
are
that angle back.
still, as opposed to the algorithm which he very elegantly put forward recently in JCC, that provisional is still being followed a lot.
Yes.
Yeah.
Thank you.
Yeah, 3-1 actually in the poll. Yeah.
Wow, 3-1. Yes. No, but question I always say, so absolutely, I fully agree, but what if you say the same provisional approach for the left main?
No.
Right.
What
Side
will
branch.
be?
Side,
Yeah, no, no,
size
but
of
no.
the side branch.
No, but that's
this
the key.
was- This is LED or
LED
routine.
Yeah, LED diagonal, yes.
Routine LED
Right,
diagonal.
yes.
This is a complex.
And then question is, what will be the routine distal left main bifurcation? So people still do provisional. I know last week when we had our CCC symposium, despite there is so much discussion was about the provisional, everybody still wants to go provisional. For the left main I'm talking about.
All right, let me put a poll up.
Yes.
This is this
so you're delivering now a long stent, right?
access with the
38.
thousands of interventional cardiology by
Take a seat.
social media is an unprecedented event in our webcast.
Some die.
So one
Good,
stent
pull back.
would cover everything.
I think
You
this
may
is about
need
okay.
one more, yeah.
One more, right?
Take a
And you can see the distal flow has been improved
very
Yeah,
good.
definitely.
a lot.
Good.
I
Yeah.
mean, this is with the
Going up.
stent in, and
Yes.
it's a
Okay.
very nice distal flow.
Yeah.
Now
Okay.
yeah.
This
What
is
we
a
can do-
3038.
Size-wise, what did we
30.
pick here?
3038.
Yeah,
And
makes
of course we have the I was ready a little later, which we'll do.
Now, if you want, we can take the same wire out and go to D1.
Yep.
So, don't use the same wire, right?
You know, I think the idea of placing the stent to stabilize things quickly here
Yeah.
is very reasonable, particularly with all our contemporary stents where the 3.0 can easily be flared proximally to 4.0, 4.25. So I think intravascular imaging after the stent placement here is going to be very helpful to guide
picture?
your flaring and your expansion proximally.
Okay.
Yeah, we
looks good.
highly believe by imaging guided high-risk PCI.
Okay, so now you want me to go to D1, wire it?
No, but
Habib,
question, we're
what
doing
is
proximal
the
segment more?
use of
No?
percentage use
No,
of
why do you
OCT
need
in
to
your
do
lab?
I think there's
In
a
our
disease
lab,
there.
OCT
Yeah.
is for,
Play.
first of all, intravascular imaging for PCI overall is very high. It's about 80%. But I
Good.
think
Japan, you're competing with
overall,
Japan.
we are.
Yeah.
I'm talking about
It's okay.
Emory University Hospital, and then OCT is about 10 to 15%. It turns out that just the facility of IVUS and
IVUS
not
ready?
dealing with contrast and stuff is helpful, although obviously there are techniques being developed to use OCT with minimal contrast as well now. But, I mean, we've fully bought into the importance of sizing the stent and optimizing it based on
Do proximal
imaging.
dilatation before I was.
Especially,
How much would be the use of IFR and FFR?
3.2, bigger, 3.25.
so I think the overall, of all our PCIs, physiology is about 20%, 25%. But if of all our diagnostic caths, it's probably about
Get
10 to
IVUS.
15%. It's obviously dependent on which kind of patients are coming in, have they had stress tests, and so forth.
Dr. Kinney, I have a question about the technique here. You wired the D3
Yeah.
and you didn't wire the D2. Was there any reason why not wire both of them at the same time, or what was
That's
the
a good
choice?
point. Actually, and look at that. This is a classical example. The vessel which you wired is better flow compare or no pinch. Remember, there was much decreased flow in D3,
Yeah.
and D2 was okay. Now, by wiring the D3, D3 remained patent, and now D2 has become ostial subtotal, although a small vessel.
Yeah,
So
and it's
b-
improving
just
over
wire it,
time.
yeah.
You know, sometimes it's just spasm, sometimes it's a
And we'll
shift
give
of
some
the
medicine,
plaque.
yeah. So now question was that, do you put two wires? I mean, the question is that do you, a side branch, do you protect two branches? So I can tell you in our lab, it's very rare that we'll protect two branches. We just decide with one and then go to and so decide which one,
And
yeah.
the reason to make the procedure less complex, too many wires, you have tangling of the wires.
Tangling,
getting focusing-
thrombus, and all, everything, yes.
I think I just want to highlight a difference of opinion. Though I was trained by Samin Sharma, I'm not a believer of leaving the wires in the side branch. I have a belief of same complex, make it simple, and what I call is a no-touch technique. That if you think you're not going to go to the side branch, don't go near it, don't wire it, just put a stent and come out. And I think a lot of publication has already come out, and the work that we have done here with what is called as Orbit FFR, which is closed for enrollment, will be analyzed soon, and we'll see where we are going to present it. Will show some imaging data saying that this that if there is based on the side branch size as well as a side branch pre-diameter. If you don't have disease, I don't think you need to wire the side branch. You can just stent across. If it goes down, then you can take care of it after.
I agree with Dr. King.
Yeah, my approach would be somewhere in between. If you think that you're not going to do anything to that side branch and let it go, obviously you don't wire it.
Yeah.
But you're going to end with some enzyme leak for sure. If you think that you may stent it, then I always wire it because the access sometimes is easier when you had the wire before. But I do think that, like Antonio Colombo used to do like 4 or 5 wires on the case to preserve any septal. This is like an overkill.
Yep, agree.
Okay.
Right. Let's see what
When you
the
have
diverse-
multiple wires, there will always risk of entanglement and risk of thrombus.
Yeah.
So
So you can see almost nicer position.
Yes.
And the expansion is very nice. I mean, so that's giving the fact this was a calcified lesion.
Now you're
Uh,
coming more proximally.
We need 3.5 balloon.
we may have to put a stent, no? If there is something, let's see. I mean,
You
so
mean
far it's a
proximally,
nicely
no? Yeah.
opposed.
No.
vessel.
No, but you have to expand, yeah.
You can
Oppose-
expand a little bit
In
more
Yeah.
proximal
with a high
portion, I
pressure.
think it needs.
See, you need expansion. Now the proximal calcium,
What
but
size
good
you
lumen.
took? 3.5.
Yeah.
Okay.
That
3.5
is-
Now
non-compliant.
this is
that
the
happened, right?
ostium. Let us see if there is no dissection.
No.
I think we can
Good
leave it
lumen.
alone. Yeah.
Good
I
lumen.
think, I
Yes.
think proximally 3.5, and
Yeah.
you might even go with a 4.0 eventually proximally.
Can you get us
Um,
a cross-sectional area at the proximal edge of the stent?
Distally, it was beautifully
Yeah.
sized, and the expansion.
So again,
lot of
I don't
plaque
think you
in the
need to
proximal.
overkill it. If you have a CSA of about 9,
Yeah.
Yeah.
that's good enough. I mean,
Yes.
you don't have to get like 11 or 12 because there
Well-
always could be a price for that.
Yeah.
No, you're right. I mean, there's side branches you worry about.
And even a longitudinal dissection. So I usually
Yeah.
prefer short balloons, not
Yeah.
long balloons,
Yeah.
because the energy is not propagating down the stream to the vessel, and a short balloon would prevent you some longitudinal dissection.
Ron, away from 2 or 3 stents or balloons here, a more practical question for you, and I ask it in complete sincerity. As I had mentioned, our STEMI
What is the
networks
proximal?
are globally
Good assess?
spread. And I am often asked by people if they were to attend a meeting in the United States, TCT or CRT, tell me why should they attend the CRT?
Oh, the CRT is more a cluster of boutique meetings. You know, when you have a convention center like meeting, it's a very hard to
Right.
focus. You have too much distraction. The focus on CRT is really on education and taking home message, which going to be impact your practice. And I think
Go further to
this more
moderate
intimate
pressure.
interaction without the intimidation of a convention center-like meeting, which has its own role. It's like a trade show. So for individuals, that what we try to offer at CRT.
How many years now?
This is going to be the 22nd year. It's going to
Ah.
be this year on the last week of February.
Right.
And I would refer everybody to the crtonline.org because we have a lot of the slides there and the dates and the announcements.
Habib, how many years for the Emory course now?
Well, we're in the 38th year,
Unbelievable.
and Ron was there in the early days. We were chatting on the way in. Ron,
Ron started his career from Emory.
yeah, we have one of our claim
Take
to
the wire
fame
out.
is not just Andreas Grunzig, Spencer
Take a
King,
picture.
and John Douglas, but Ron
Very good.
Waxman and other leaders in the field that have started their work
Vasodilators,
there.
Good.
But one of the things, Shamir, we've done is that we've brought together 22 centers from the southeast of the United States, and so we have representation for all the centers there. And our meeting is also in
Cranial,
May of
to
next
show the
year,
vessel.
and you know, it's exciting. A lot of live cases like you guys are doing, and obviously you're all welcome to join.
You've got a phenomenal team, and please tell John Douglas that our invitation for him to come and visit us at the live cases is still there. I asked him, requested him at the last time we met at TCT, and I actually have a very fond memory of my interaction there. He was attending one of the sessions, and his notes were more copious than a medical student. It was unbelievable. Such a diligent and what a amazing teacher he has been. Mike, how does a person as busy as you get so much time to have created and I want to learn
No.
from you the progress with WikiDoc and the WikiPatient.org as well as the clinical trials. I mean, now it's you've got the whole globe, hundreds of thousands of publications being archived and viewed simultaneously.
Yeah, so it's not just me, it's 40 to 50 young people working continuously in Boston on updating the contents, over 100,000 chapters, edited millions of times. It's the new generation. It's open access
100,000 chapters?
Yeah. Yes, so over 15, coming up on 15 years now. So like you, and like Dr. Keeney and Dr. Sharma and Dr. Waxman, it's about people, and it's about passion.
Yeah.
Individuals can make a difference given their passion.
You know, one thing about back to the case, we were giving some vasodilators in a regular
Okay.
situation. Again, with no impella support, you're going to be scared because the blood pressure can really drop to a lower ratios that it's going to be very, very hard to overcome the EDP. Here with the impella, it's really seamless. I mean, even though the blood pressure on the monitor dropped somewhat, but the patient is completely stable, you can tolerate those vasodilators, and also seeing that the diagonals are still preserved and the flow is
Right.
improving into the main LED.
Excellent.
Good. So now we got about.
Let me just,
Yeah.
I just needed to highlight based on why you said why people should discussion TCT versus CRT. Two reasons, I think. CRT, because Ron Maxman is the first person, I would say. I do not want to highlight it too much, but something that I want to mention is about women. That he was the first one, probably.
Yeah. Not probably. Yes.
Not probably, the first one.
First one.
Yeah.
Who
First one.
made that thing about women in interventional cardiology. He made the group, and every time in his meeting, there is always, like he said, a boutique about how to promote women in this small interventional group, and he's the first one who actually started a live case by all women.
Which was
And the
performed by
credit was-
Dr. Keeney, and she was the first in the world to do all women live case, operators, patients, moderators. This
Staff,
was amazing.
staff, everybody.
Staff, everybody.
Yeah, they
every-
actually kicked all the men from the lab, including Dr. Sharma. That was the
I know.
condition he would
I know.
have in the control room, and,
Yeah.
and the case was beautifully
Yeah.
was well received.
Yeah, so that's the reason I would say you always, because he mentioned he always has something new, something about health. Last time he invited all these people who were big in health, right?
Correct, health.
About promote health among physicians. And of course, you know, he's in Washington. I did ask him, how do you get all these prominent people? He always have the top politician, including the ex-presidents, come and give an address to all the physicians. So I think that is why it is a must meeting for everybody to attend.
Anu, regarding physicians' health and well-being and relaxation, you have always been a big proponent of yoga.
Yes. I am, and International Yoga Day is just coming on this Friday, which will be a big celebration in Mount Sinai. And I think as an interventionalist, I just want to promote that every interventionalist have to follow a healthy lifestyle, because we are wearing lead. Posture is very important, and long hours, so you got to keep yourself fit so you can keep doing these cases for yourself, for the patients, and teach the globe.
So how about yoga during the case? Like a few exercises.
Ask my staff what I tell them.
So maybe next year too, you're going to show us a yoga,
yoga move.
mini exercise during the case.
Yeah. So
To relax the team.
I think-
particularly in the long case, yeah.
I think the whole time she was doing this case on one leg,
Yeah.
and the other leg was stretched out.
Yeah. So no, just to come back to the point, I think one of the great thing for the CRT, although this year was a little unfortunate, my flight got delayed. Otherwise, we relay from here and go there. It's the personal touch, the dedicated, short, focused, subject-focused topics, whether it's a plaque vulnerability or the bifurcation case, CTO. So I think that's really one-to-one touch gives immense comfort or learning to the people who attend, and that is the key. And also you actually encourage a lot of people to come and present their abstract and their work.
Correct. Everyone
That's-
that
yeah.
wants to present is
Yeah.
invited,
Yeah.
and fellows for free, and
Yeah.
also we fly them and give it at the hotel for
Right.
free. So
Yeah.
all the revenues in the meeting goes back into the meeting, and we invited a lot of faculty and fellows. We have 250 fellows that we support their flight, their hotel, their education. So it's really a good opportunity to people to take advantage of.
Samin, we have another incredible statistic which Mike was able to poll the audience.
Yes.
Yeah, so we're talking about complex left main bifurcation disease
Yes.
with osteoarthritis and LAD disease. What's your approach? DK Crush leading right now,
Okay.
64%, T at 18%, Colette at 9, Provisional at 9.
Oh, provisional is single digits, right?
Right.
Yeah.
Yeah, that is what in the Bifurcate app. Bifurcate app, when we have a 011 or 111, we don't even have provisional. We
Right.
actually have, you decide which bifurcation technique and then you follow that.
And then what's your general
Yeah.
imaging approach?
Yeah.
OCT 10%, ultrasound 38,
Yeah.
angio only in 38%.
Beautiful.
in, left main disease.
Okay, so great. Now what I'll do is, while we are getting ready, I just quickly go, knowing that case technical points all have been shown. We always talk about 2 points, and what I'll do is, for the purpose of cut short, I just try to show the slide and the concept, and maybe take an opinion in 1 or 2 key slides from both our expert, the moderators here. So one is the FFR correlation with lesion morphology, and second is the concept of the defined PCI trial. So FFR, clearly there are a lot of features which have been published, non-invasive as well as invasive, which correlate with the abnormal FFR, and one of them has come particularly with the plaque remodeling and low attenuated plaque, and so with the Jagat and initial paper showing. So one is the plaque burden and morphology. This actually has shown that once you have adverse plaque characteristics, which are non-calcified plaque, more than 70% luminal stenosis, positive remodeling, spotty calcification, low attenuated plaque. So clearly those have corresponding decrease. More you get, more the blood flow decreases, and so they're very nice picture in terms of predictors of impaired myocardial blood flow and predictors of impaired FFR. And this actually explain many times when we see the 50% lesion, and you say, we can't believe it, this patient will have a FFR of 0.8. And this may be many of the features which we are not seeing only by angio, and I'll show you some OCT data and the Habib's work. That key is that it's probably something in those non-obstructive lesion angiographically which is making FFR positive. Ran, your comment on this?
No, I totally agree with that. Although, again, I do believe that you cannot spare the imaging, because the imaging, intravascular imaging, would leave the guess game out of what you're doing. So I think FFR could be affected by the morphology. Imaging is very good complementary to get the impression. So sometimes even if you have an FFR which tells you don't touch, we would persuade by the intracoronary imaging, because the morphology is very threatening. And as I'm going to talk about it in my talk, there are those nasty lesions, as we did last week. very aneurysmatic, and very one that prone to potentially have a vulnerability that should be treated despite the fact that the FFR would be positive.
Beautiful. So this actually they gave a very nice example of the CT positive stress test on an angiogram moderate lesion, but this patient will have had a lower FFR. So clearly the second point was lesion specific and vessel related determinant of FFR, and this actually have shown that clearly some FFR positive lesions are even they looks non-obstructive, but based on the plaque characteristics and so. So then there's another paper on impact of coronary lesion geometry on fractional flow reserve, many times irregular lesions, although looks non-obstructive, but they may have the higher plaque burden, but just because of the eccentricity and they will shown on the various aspects as you shown here, the positivity on the FFR lesion with angiographically were less than 70%. So these are the various predictors, and so another paper which is very interesting, which by Habib's group, that high coronary shear stress in patient, because always question comes that you have either positive FFR or negative FFR, but event rate doesn't occur in 100% or event rate doesn't occur in 0% in FFR negative. Is there something else to the lesion? And this is very interesting. They come up with this plan that coronary shear stress, that you can say based on the vessel segment, it's a very, and I'll ask him to comment on it, that how this wall shear stress is calculated and can predict that lesion, moderate lesion, we know that 90% lesion give trouble, but our question is, more often we see 50, 60, 70%. What else can we do? One, of course, the imaging. Second is there anything else? And of course, with the wall stress, shear stress, with Habib leading it, maybe I want him to comment on it.
Great, thank you. So I agree with Ron that the three-dimensional geometry is really critical. And it turns out one of the major determinants of wall shear stress is the curvature, the angulation, the very complex three-dimensional geometry that frankly we don't capture on the angiogram, we don't capture by itself on the IVUS pullback or even on the OCT pullback, because it doesn't give you the curvature and the angulation. The other aspect of wall shear stress besides the three-dimensional geometry are the boundary conditions. So what are the pressure and what is the velocity of blood at various locations across that stenosis? So ultimately, Dr. Sharma, in this paper, we found that if you take all positive FFR lesions, so these were all lesions that had an FFR of less than 0.8, those that had high frictional force of blood against the wall or high wall shear stress at the throat of the lesion were actually predictive of future myocardial infarction. And what I like to say about this is that it's not just sort of a nice little biomarker. The nice thing about wall shear stress is that it's actually anchored in 20 years of vascular biology, which actually delineates all the pathways that link low and high wall shear stress to plaque progression and plaque vulnerability. I think for us, it's just a way to bring it now in the cath lab and take all that vascular biology, add the computational and the imaging, and provide it as a clinical tool. So we are pretty excited about the development and more to come.
And Anu, you are working on some paper on this also?
Yeah, we have two papers. I think one, Dr. Hamadi is actually the author. Essentially, our yellow trial where remember we gave statins and did the imaging on these patients. Yellow 2 actually where we had both OCT as well as NIRS, where we showed giving high dose statin, there was a decrease in the yellow plaque. Which then by the OCT showed that that was cap thickness and that correlated with the wall shear stress improvement. So that is the sub-study of the yellow, and the other one where we did this wall shear, which has been accepted as a research paper in circulation intervention, is the technique, because lot of things for interventional cardiology is once you do two stent technique, there is always this debate. That do you kiss, do you pot, and the steps are increasing. As an interventionalist, as you do complex, I am a big believer of decreasing the steps and finishing the case faster, so you don't get into subsequent problems. So what we did was to check patients who had POT versus who had only kissing balloon and check the wall shear stress, and there was no difference, because there is only animal studies to show that actually POT should be done in every case. There is no in vivo study to show that. So we were the first one to do the wall shear stress and show that. Right now it will be coming next month in circ intervention.
Great. And now the FI just shown very elegantly simple. It's almost 2.5-fold gives the predictive value odd ratio once you have a positive FFR along with the wall shear stress. So then question is CT plaque vulnerability in relation to the microvascular dysfunction, that you can check FFR and IMR, and actually has shown that the both FFR and IMR tertile are associated with thin cap fibroatheroma on the OCT. So very nice elegant paper on this plaque vulnerability. So this actually puts things together that it is FFR as well as the coronary blood flow reserve. So microvasculature is also coming back now. So it's not only just the FFR, the CB coronary blood flow, microvasculature in various studies have come back, and of course the CT will be a very useful tool for that purpose. So I put the link between plaque morphology and ischemia, and it looks like there's a necrotic core causing endothelial dysfunction, causing positive FFR irrespective of the obstruction. So this actually puts it very nicely by Jagat, I hope he's there, that the editorial for this paper, that family of flow reserve indices and coronary revascularization, miles to go before we sleep. He's saying that although there is an immense excitement regarding various tools for direct or computerized assessment, but still event rate occurs in 10-15%, not in 100%. So therefore it's okay. So we really need to come up with a better tool. So just to go to second is a defined PCI, but the concept was that many patients, you do a PCI, you still have a positive ischemia in the end. And all the studies have shown you have angina, and that whatever residual, some cases you do FFR, the remains less than 0.8 almost in 20+% of cases, and those who are positive FFR post PCI means less than 0.8 have a higher event rate. So the concept was to find out based on the IFR that angiographically you have done good, and now you see how many patients still have a positive IFR at end of successful PCI, and that was the concept of the defined PCI. And just to, it was more of a registry study of a patient with a long lesions or multivessel disease, and they measure the IFR pre, all interventions were done, and then they have IFR in the end, and the IFR results were kept blinded, and it turns out to be the what. And then of course some of the cases could have been optimized, but basically what the trial showed, study showed is that some cases your IFR actually goes down rather than going up. So most important issue comes down to, they show various examples and so that about 24% of cases after successful PCI had a positive IFR, means less than 0.89 after intervention. So Ran, what do you say about this statement, or what they observed in this study?
It's very provocative, obviously, but it tells you that you sometimes don't treat the right lesion. And I think, unfortunately, I mean, you are very satisfied and gratified, but the patient would not appreciate it if you don't treat the right lesion. So it's not what's seen that needs to be treated, it's what really caused the ischemia. So I think it's very important to do the IFR pre and to identify, and that's, I think, the advantage of the IFR, that you give you on the longitudinal lesions the areas that needs to be treated. And I do think that if you did not complete the job and the ischemia is still shown by any of those physiology, you have to dig in and to improve it. Now, the other question, if you have 0.90, do you need to go to 100? That's part I'm not 100% sold into, but definitely you should not leave the FFR or IFR that has not achieved the threshold and reducing the ischemia.
So this basically, they show the various examples. Sometimes there is a within the lesion, proximal to lesion, distal to the lesion, and just to show that if you have focal, you know, many times you will have a positive IFR because of diffuse, and you can take care of that because you cannot put a stent. But focal was present in 80% of cases. So if you can take care of that additional stent in that focal, your ischemia will go down based on the IFR from 24 to 5%, and that was the understanding with this. Now, which lesion? Many of those FFR less than 0.89. Angiographically, the more than 50% or less than 50% were equal distribution. So these were majority happen in the LED and the small vessel. So key is this major trial which they have started now, define GPS, that is guided physiological stenting, about patient standard of care, or you do IFR guided therapy, pullback, and basically if IFR is still less than 0.89, go back and try to normalize by additional stenting. So this actually will be another trial within our interventional cardiology, which will make a real sense to how to optimize why some patients angiography looks so good, but they continue to have symptoms.
Yeah, but you can
so
always argue that medical therapy is still a treatment.
Yeah.
So even if you leave some ischemia, if it's not that critical, patient still would be okay if you keep him in medical therapy.
I was just going to say, you got to tame. I was involved with the defined PCI trial, and Alan, and I'm going to have a few slides later. Many of them you have here, but I do think it's provocative for us to use physiology as an endpoint, because ultimately most of what we do is try to improve ischemia and angina, and there's a way to check it in the cath lab before your patient goes home.
And if we'll go with Dr. Kinney approach, less is better. If you do now on this case that we just show beautiful result in IFR, and it's going to show you an area, again, it's more stents, it's more complexity, it's more side branch occlusion, more CK rise. So you have to look at the trade-off to be slave to do everything just to satisfy the IFR. So we have to take into content, what is the complexity that would be associated with.
I think the punchline of the defined PCI, as Dr. Sharma said, is two things. Number one is that you leave behind 25% ischemia. This is not mildly abnormal. This is ischemic lesions. And number two, if you take those 25%, most of them are focal, and of the focal ones, a third are in the stent, a third are proximal, and a third are distal. So you could argue if you're leaving a lesion behind in the stent, that you should post-dilate. Proximal and distal, then you have to do an analysis. Is it worth putting another stent? Is the cost worth the benefit?
And the key was they did mention one of the important limitation of the study was they did not use the imaging to decide the stent length and so that's the key.
Or expansion within the stent, because if we do imaging, I don't think you need to do both. If you do imaging post, you probably get the answer.
Yeah.
But again, it's all anecdotal right now because we don't have randomized clinical trials.
Okay, so I just want to complete this, our one, that non-veggie parameters now can tell about the FFR and of course why non-obstructive lesions sometimes get trouble. And second is the concept, the residual ischemia as defined by the defined PCI left in about 1/4. And the concept makes sense, but as you mentioned that once it show benefit, then only it really will become part of our armamentarium. So very quickly, 3 questions we always have. The one is the adverse plaque morphology associated with lower FFR except 70% luminal stenosis, positive remodeling, non-calcific plaque volume, high attenuation plaque and low attenuation plaque, which we already clearly said. It is the low attenuation plaque is the troublesome, not the high attenuation. Second question, following are the proposed link between plaque morphology and ischemia low FFR, except plaque with necrotic core, large plaque burden, plaque with low wall shear stress, plaque with high wall shear stress, and positively remodeled plaque, and clearly the low shear stress is okay. And the last question, what % of patients the defined PCI has a persistent ischemia defined as IFR more than 0.8, less than 0.89, will complete that, correct that, and that basically is 10, 15 to 30, 30 to 50, 50 to 70 or 70. We got various studies have shown IFR or FFR positive in about 20 to 25% of cases.
Samin, excellent review, and I think the presence of Dr. Waxman and Dr. Samadhi greatly helped and augmented the discussion. Just to let our eminent guests know, this is how we are at the moment 67 minutes into our webcast, and there are 42 groups of live audience which we have, and some of these are as many as there could be an academic institution with 50 people in a room. Many of them use this as a CME component of their teaching.
Let me add just a few comments to shear stress. I think it's very, very complicated. Back in 1993, I published an article looking at shear stress in disease progression, not plaque rupture, and there it was low shear stress that was associated with a disease progression. And what's always fascinated me is it's not just the shear stress, it's the oscillatory shear based upon blood pressure, pulse rate, and looking literally at all these images from Fluent, at the tighter the lesion, there's a lot of oscillatory shear and circular flow and flow disruption beyond the lesion. And when you look at angiograms, you know this in STEMI, a lot of the times the plaque rupture is on the distal shoulder of the lesion, not on the proximal shoulder or the throat. And so some of it may not just be high shear, but high oscillatory shear in those regions just distal to the stenosis.
Would that alter the management?
No, I don't think so. I think it doesn't alter the management.
But
And then
we just understand the physiology and the effects of it so much better.
I think we have a lot of work to do on the physiology side. And then clot. I mean, we think we can see clot on an angiogram, but when you put an angioscope down, if you had 100 cases of clot on an angioscope, you'd see 14 on an angiogram. So we grossly underestimate the incidence of thrombus on angiograms, even though we think we do a good job.
Good. Okay.
Sameen,
We are ready to come that side now, and we'll make a last word from Anu, and we conclude our today's case number 120.
yes, 10 years of accomplishment. Anu, words about the case and about 10 years of the live webcast.
I think Dr. Sharma will show you the history of the live webcast slide a little later, but I just want to say why I wanted the live webcast. As you see, as a young attending and getting into growing my career, what the best thing by doing the live webcast is what Dr. Gibson mentioned is a passion to teach, and a passion to teach people all around the world that what I have learned and what I can teach other people. So instead of me going around the world, happened with this particular happened is the world came to this place, and what we call this right now the Temple of Interventional Cardiology. That everybody who comes to Mount Sinai gets the picture. Like when they go to India, they go to Taj Mahal, and there is a picture everybody takes. They sit on the bench, Taj Mahal in the back, and everybody has that photo that they have gone to this wonder of the world. So there is always a photo of the room too. They're saying that yes, we have been to that room, and there is a picture they take in the control room, and that is what is going to be
Taj Mahal of intervention.
intervention. This room too is going to happen, and I think that was one goal that I achieved, is that I could not travel, and I did not like to travel. Instead, able to continue teaching other people around the world by me just being here.
Look, Anu, it's been a pleasure watching you over the last 10 years. I think not only are you the best female interventional cardiologist, but I think possibly one of the best anywhere. I've watched your skills, and you are so correct in saying it. You hold the fort. The education here has been top-notch. Sameen, final words for you for this 10th anniversary conclusion.
That's it. I would be glad to complete 10 years of the vision which we had back in 2000, 2007 and 8 to see whether it could happen, and it happened, and thanks clearly the key player in this all 10-year journey, constant throughout in that all 120 episodes, yourself and Anu. I really thank everyone.
I'm looking forward for another great 10 years.
I'll conclude this with a little humorous story. In 2016, I was doing training of some sites in Tianjin, China. I took a flight from here, reached at 10 minutes after 5 in the morning, came and joined you with the live case, and we had a meeting with the Ministry of Health. I took a 1 o'clock flight back to Beijing. But that being aside, I remember that morning I came in, and Pablo in the cath lab said, "You are very well rested." I said, "Absolutely." So you can camouflage some of that. It's been a joy bringing these cases. I want to thank our eminent guest today, Dr. Michael Gibson. Mike, absolute pleasure having you here, and we'll have you spread the message of the webcast around the world.
Of course.
And to Ron Waxman and to Habib Samadi, thank you for your encouragement and for your exceptional additions to our webcast today. Samin and Anu, a pleasure being here for 10 years, and we'll join you during the next case,
In few
121 on July the 16th.
All right. Thank you, everyone.
Hello, everyone. I'm Ron Waxman. We are live from the CCC. This is the 120th case, which gives you a tremendous amount of education globally. You have seen a state-of-the-art demonstration by Dr. Sharma, by Dr. Kini, showing exactly how to do the case, going over the points. It gives a tremendous opportunity to people around the world to see and to learn about interventional cardiology. Congratulations to both of you.
Thank you. We got to do no, yeah, Dr. Gibson.
Mike.
Well, thank you so much for having me on your 10th anniversary. This has been historic and very exciting. So often, cath lab cases degenerate into the way I like to do it, and we've all been there. This has moved beyond eminence-based medicine, where the most senior person in the room is always right, to evidence-based medicine. Anyone can put a stent in anywhere. You guys get at why you're doing, not just how to do it, but why you're doing it. And I really like the segments where you went back to the literature and reviewed, some of the evidence that supports why we're doing what we're doing and having everything deeply rooted in the appropriate use criteria. So my compliments on your longevity, but also the quality of what you're doing. It's great to see. And thanks for having me.
Fantastic. Habib?
Well, I'll chime in as well, and I want to congratulate Dr. Kini and Dr. Sharma and Dr. Mehta for really a spectacular 10 years. I think that the passion that you guys exude with every case you do and all the educational aspect really is going to be, is palpable. And that passion translates into people all around the world wanting to emulate you and do these great cases. But I also like what you said, right? Because ultimately this is about patient care. And the patient you took care of today was somebody with a low ejection fraction, who had a lot of ischemia, had severe lesions, and I'm pretty sure they're going to get better. So I think we're all about making our patients better. And thank you so much for anchoring all this in evidence and making it patient-centric.
Well, I just on this special occasion of 120th, I thank all of you to be here, part of this great celebration, achievement, and tremendous comments. I mean, this has been fantastic from all the way, and importantly, the live tweet and getting the answer to very many questions was, I would say, plus, additional plus for this today's 120th episode. Really thanks all of you, and just to be part of this CCC live cases family. So every few months we do invite one person to be in the room, and I'm sure you'll get invitation from us for our future events. Thank you. Thank you.
Thank you, everybody.
Yeah.
So I think what you have seen is a demonstration of complex case. I think what we have shown in every case is the tips and tricks which we go over. Dr. Mehta, after presentation, we go over how should be done and what are the various ways that could be done. Discussion of the devices and the technical tips, which is the best probably for all the fellows as well as the young budding interventionalists all around the globe. Like I mentioned, what I've been proud of is that just by staying in Mount Sinai, because of the global reach of this educational program, I've been able to teach along with the entire group all around the world how to tackle the complex cases in a simple way. Thank you, everybody.
Okay.
Anu and Samin, congratulations to you and to the cath lab. This is just amazing. Sounds like yesterday when we started it, and now we are being watched by more than 8,000 cardiologists in 134 countries. To me, I think two parts stand out. Number one, I think a lot of our success is from absolutely having no conflict of interest, no endorsement of any products, and of course the academic of the AUC. I think as Dr. Gibson had mentioned, I think the decision which we took many years ago that each case would be followed and proceeded with the AUC grid, I think has been an important contribution. Anu, congrats also for putting in so many apps for the global use.
Thank you. I just want you to focus. This is probably our first live case here.
Ever.
Yeah, first live, the global.
Webcast.
The first webcast.
You guys didn't
10 years ago.
Yeah.
change.
I remember that was the first case of the. Thank you.